We'll start with the land acknowledgement. Before we begin, we acknowledge that we are gathered in the traditional unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that brings us together here today. And please join us in uncovering such truths at any and all public events. Well, welcome, folks, to the quarterly, albeit 1 month late, Crisis Stabilization Center subcommittee of the IPRTF. My name is Perry Mowry. I work with the Health Department, specifically the Response Systems Division. As a behavioral health supervisor, I'm involved in a number of projects that have a big behavioral health component to them. We have a number of contracts with providers in the community that are behavioral health oriented. I get an opportunity to supervise the manager of the mental health court and those kinds of pieces. So really enjoy my work and my position with Response Systems Division and just the development and aspects that are going on there. In addition to that, I also view myself as functioning as a liaison between the county and the providers at the Crisis Stabilization Center and Deacon Center for Hope. And so there's a lot of dynamics and components that go on there when we have two separate providers, Pioneer Human Services and Compass Health. Pioneer Human Services providing our withdrawal management services, detox, and Compass Health providing our triage, our mental health triage services. And so even those two providers, different challenges and different needs for them and the nature of the relationship. I think most folks are aware of the nature of the relationship is that the providers have a lease agreement in for the facility that they pay a monthly rent. They also cover the cost of utilities at the facility. And they're actually compensated for their services, at least predominantly through Medicaid, is how those services are compensated for. I suspect, I think that most folks are aware that Pioneer Human Services and Compass Health have a number of different services that they provide up and down the I-5 corridor, but certainly within Whatcom County and within our North Sound region. I don't have the numbers because it's not something that they provide to me directly, but I very strongly suspect that neither of the providers actually break even with the services that are provided and compensated for through the managed care organizations and Medicaid, obviously. And I think we're all pretty familiar with the cost reimbursement model and that sort of thing. And really at this point, if folks aren't aware, it's really a fee for service model at this point in time. We've continued to push against that because the Crisis Stabilization Center is open 24/7, obviously has nurses and prescribers and et cetera on staff during that entire time. And so if they have low census, or if they had, for example, no census, it hasn't been an example, then there would be no, compensation whatsoever. So we have advocated along with the Behavioral Health Administrative Services Organization, HCA, and et cetera, for what's fondly referred to as a firehouse model. That being, if you will, that we need firefighters on staff all the time because anything could happen. They have to be prepared. A very similar dynamic when it comes to the Crisis Stabilization Center, regardless of what the census is or how many individuals are there from a particular managed care organization or coverage by a managed care organization. The staff have to be there in a specific amount of staff as per requirements of Washington Administrative Code and RCW. So at any rate, just a real quick background, in regard to that. I thought I would start with just reviewing the census, and I have a pretty explanatory document here. Jill, I'm not certain if I can share screen. Will that work?
Yes, you should have that ability.
Thank you. Let me find his real quick. I won't probably be able to see raised hands as I share this, so forgive me in advance. I may be able to see. There's not a whole lot of folks there. Can folks see that? Is it?
Yeah, we can see it now. Very.
Does it show? Is it close enough?
Yeah, I got a big screen though.
Okay. Fair enough. So just super quickly, what I'm reflecting here is the sum totals. I just basically took the quarters, if you will. I'm showing the sum totals for the year of 2022. The top portion is Pioneer Human Services, Detox, and I'm showing the sum totals of 2022 and 2023, if that makes sense. The yellow lines are each reflecting a year. Same exact approach in the bottom, although that is Compass Health, of course, for 2022, 2023. I thought it would be helpful to show, a year and then the most recent year. Super quickly, the way that this is put together and the data is gathered, program bed days are figured. Each of the facilities has 16 available beds on their side. Again, Pioneer Human Services, Detox, 16 beds, and also Compass Health, 16 beds. That number of 5,840 program bed days is simply the multiplication of how many days are in the year or month or whatever we're doing times 16 beds, and that comes out to 5,840. The utilized beds, of course, is a number that we have, at least in the business. What I hear is heads in beds at midnight. And so that is the count at any given time of the census. The utilized beds is obviously a percentage figure, based on those two numbers. Unduplicated served, we have a number of individuals, obviously, that struggle with substance use disorder and or mental health challenges that return to the facility and get services. And so we do ask for data input on unduplicated individuals served, just to kind of get a sense of that number of, if you will, new individuals that were counted once.
So Perry, quick question.
Yeah.
So if that's 966 for unduplicated served, that means of the 4,480 beds utilized, just roughly 1,000 of them were unique individuals.
Correct. And again, one of the things that I've sort of reflected on, we get into confidentiality, challenges here, of course. There's private health information and et cetera of who are our high utilizers and, and those sorts of things. But indeed, you're accurate, Todd, that is what it's reflecting. And so great question. Also, in terms of referrals received, now an individual certainly can be referred to the facility, but for example, the facility says, yep, come on in, we've got an available bed open, and the individual decides to decline. They, choose, I've changed my mind, I'm not going to come. Or the referent source maybe declines that it's like we found an alternative, that sort of thing. Or of course, the facility finds that the individual needs a higher level of care than is able to be provided at the facility. So there is a difference, if you will, real quickly between, referrals received and utilized as well. Yeah, Peter.
Oh, thanks, Perry. And maybe you're about to address this. I'm not sure, but I do have two questions looking at this. In our community, we obviously have significant crisis in substance use disorder, mental health disorders, and such. And so it's surprising to see, or I'm questioning why the utilization rate is so low. I would think that it would be much higher for both of these facilities. And then the second question is, I see that the referrals from the jail for detox are zero. And I was just wondering if you could speak to the role of our jail as a referrer for both of the facilities. Thanks a lot.
Sure can. And so of course, in terms of why is the utilization, percentage at, where it is, how come it's not higher? This is to some extent conjecture on my part. So just want to, offer that, that piece. But I think it is a combination of things, and certainly feel compelled by virtue of my responsibility to continue to work at barriers or challenges or whatever it happens to be that has the number at this point, and forever pursuing a higher number of that, and I think that jail, I don't know in detox that it's a great example, but I think that it is actually a pretty good example of why is that zero. One of the things that the providers have done is been communicating with us and communicating with the jail. And I think everybody's aware of our jail behavioral health services group. Lifeline Connections provides that service. So communicating with them and saying, listen, we're here. And if an individual is being released from jail that is going to some kind of mental health services or possibly long-term SUD treatment services, we can be a stopping place for them. Oftentimes we don't know when an individual is going to be released from jail. We don't know the day the individual is going to be released, and we're trying to arrange care coordination for an admission to a facility and trying to match those things up. One of the things that we run into as far as a challenge in that given situation with detox is they do have to meet specific eligibility criteria for the managed care organizations in order to get authorization to provide the service. So I think that folks are aware of pre-auth, and that sort of thing. Generally speaking, an individual that has been in jail for a period of time, therefore, at least theoretically, and to my knowledge, in our jail, it's accurate, not using substances at that point in time, they won't actually meet criteria necessary for this level of care from an insurance company. So that makes sense, in terms of the detox program. I'll briefly make reference to, we see some numbers with Compass Health relative to the jail, and that is oftentimes individuals being released from the jail that have been identified as having a serious mental illness or needing, additional and ongoing services following their release from the jail. And so really have been able to engage and further develop that kind of programming as a stop place for making sure the individual has medication, making certain that the individual has connections to whatever those resources they might have had, a prescriber, et cetera, in the community, or even, and quite often, placement in a longer term, up to 30-day, et cetera, type of mental health stabilization program. Generally speaking, in the Crisis Stabilization Center, the Ann Deacon Center for Hope, the length of stay is 3 to 5 days that can be authorized by insurance companies. It gets pretty tough beyond that. The insurance companies are not as willing to give authorization for. It does happen, but they're less likely for detox, if you will, or mental health stabilization to allow a longer stay. But let me drop back to the first question in terms of why are the percentages where they are, and what can we do in that regard. And again, from my perspective, I think that there's a number of reasons that is true. one of them that's oftentimes I think misunderstood. There is very specific requirements within Washington Administrative Code and RCW relative to the level of certification and licensure that both Compass Health and Pioneer Human Services have at this facility. So there is a base level of care that they can provide services. I'll throw out some really basic examples that are, super understandable. For example, neither of these programs can accept an individual that is on oxygen, that is on medically prescribed oxygen. It's illegal. There's safety issues, and they're not certified by the state at a facility that will allow, an individual. So that's an exclusionary criteria. We typically talk about that with law enforcement and other folks. And it's like, listen, if the individual is on auxiliary oxygen, we're not going to be able to admit them. If the individual is unable to care for themselves relative to daily living, basic daily living, continence, those kinds of things. There is a staffing level to be able to support that individual. And so, again, we come into, there's a certain level of care that's being provided here. And oftentimes, when I communicate with folks out there in the community, their understanding or belief system is that the Crisis Stabilization Center is similar to an emergency room. Not accurate. For example, if there is some kind of threatening primary health issue going on for the person, an example a lot of times is they'll obviously do blood pressure and do some basic measurements of an individual when they come in. If an individual comes in and has high blood pressure, has a history of blood pressure issues, and doesn't have medication, really inappropriate for that individual to be, admitted to that level of care. So those are some of, and there's others, but I just, I won't belabor the point. The other thing that we also see is, and we're, continuing to work with, so we've identified a number of the I think details around this question that you asked, Peter, and I think it's a really viable question, and continue to go, okay, so what can we do? What do we need to increase the staffing model and maybe bring in some additional resources? We can't ask the provider to do that because, as I said, I think that they're, sort of barely making it on a, a cost level. But is there some other resource that we need to bring in order to, make that occur? Those are some of the discussions that begin to happen. I think that also fentanyl has played a significant role relative to both sides, actually. We know that individuals oftentimes that struggle with significant substance use disorder may also be experiencing comorbidity relative to their mental health challenges, and vice versa for those individuals, which obviously significantly compounds and affects if they are taking their medication, if they have a mental health issue that is being treated by some kind of medication, and they're using other substances. It's going to have a fairly significant effect on that person's stability and their baseline and those kinds of things. So fentanyl, I think, has been a real issue and challenge here, in regard to both of the sides, as well as we've been working with quite a bit recently, Pioneer Human Services, the challenge of benzodiazepines. And sorry, this gets into a little bit of detail, and some folks may know this and may not. Benzodiazepines like Valium, if you will, that's the most commonly known benzodiazepine. One of the unique aspects about that particular substance is it has an extraordinarily significant half-life. What that really means is that it stays in the system for an extensive period of time. And as the individual begins to wash that out of their system, if you will, stop taking it and washing it out of their system, they have significantly increased risks of life-threatening withdrawal. Withdrawal from alcohol can certainly be dangerous. The withdrawal process is fairly treatable, if you will, not as true for benzodiazepines. And the individual can go into, withdrawal symptomology that can kill them, is really the short version of it, and, not get overly technical. And so the liability of admitting an individual that is on, that has been on benzodiazepines for a period of time. They'll do a urinalysis test, of course, for the individual and so forth. And I think that most folks are aware too, sometimes individuals coming in that have substances on board are not the most accurate historians in terms of when they're reporting their use, that kind of stuff. They're concerned about stigma and being judged and et cetera. So those are I'm kind of staying with those. What are the factors that are sort of driving this, bed utilization percentage? I think some of the other factors have also been cultural within if you will, in the communities of the providers. That it's like, oh, this person's way too combative, for example. Well, that can be, a perception that could be argued, if you will. And it's like, well, then what can we do if an individual is verbally saying that they're, willing to, but maybe experiencing, a psychotic episode at this point? Is the, individual, et cetera. You get where I'm going, with those particular pieces. But I don't want to disregard that. I think that there are some factors, and I'm very interested in these, that have to do more with the provider culture than necessarily with more tangible components like I was sort of describing before. Understandably that would, sort of arguably be, well, what's the percentage? Well, I don't know that I would be able to make a guess at that. But those are the arenas and areas that I spend quite a bit of time saying, how can we provide you, additional education? Would you be willing to have the staff come to a trauma-informed care, training as an evidence-based practice? And the providers have been, and et cetera. So I think that's an ongoing process of work. And that's what I would offer without data to prove it, Peter, from my perspective of,
Sure.
why are those numbers, what they are. One of the things, and I think that this is worth mentioning because it really was a result of the work with the providers, the relationship that I believe that the county has with the providers and our BHASO. I think that most folks here are aware that Joe Valentine retired. He was the director of the Behavioral Health Administrative Services Organization. Jan Rose Ottaway Martin is the new director. Well, I got a call in December from, actually it happened to be detox, but I think that there was, some similarities going on within the mental health triage, wherein they had individuals that were coming into the detox facility that had private insurance, not, Medicaid, if you will, but had private insurance. And they would, process that whole thing, bring the individual in, gather information, and call the insurance company to get a pre-authorization for, a 3 to 5 day stay. The insurance company was authorizing the stay, but then when it came to actually invoicing the service, what the provider didn't know at that point in time, and unfortunately what was occurring was the individual, for example, had exhausted their lifetime capacity of their insurance coverage for detox services or SUD services, or the individual had an extraordinarily high copay, in relation to that, and the insurance company said you need to collect the copay before you can get the the payment from us, et cetera. So the director of the detox program called me and said, hey, we're considering only accepting individuals that are on Medicaid because we know we're going to get paid, and we have lost, and he had estimates, actually some very specific estimates of the loss that they were experiencing, and it was fairly dramatic on a monthly basis. Keeping in mind that Pioneer Human Services also runs the detox facility in Skagit, as well as up in Island County for Atua. So I was able to connect Pioneer Human Services with the BHASO, who receives some funding to offset some of these challenges. They receive funding from the state to offset some of these challenges, but Pioneer Human Services' understanding was that the criteria for that and the reporting for that did not allow for coverage of individuals that had insurance, but the insurance wasn't paying. kind of thing. Anyway, they ended up working that out. So here I am driving home saying, I wonder how the community is going to respond to the message of a provider saying, hey, we're not going to admit individuals with private insurance anymore because we're losing too much money on this basis. And so
Right.
it was thrilling to actually have the support of, particularly Jen Rose. She's been extraordinary, very, very sharp, individual, and the ASO who have standing and existing contracts. So it was just really a point of clarification that it's like, if you make your efforts to get coverage and you don't receive that, you can invoice us, you can communication with, we need this information, but we can, reimburse you for those individual services. So again, a great example of, of a resource. And,
Great.
yeah.
Well, Perry, thank you for that. I have to say, I have to run to a 10 o'clock meeting, and I really look forward to talking with you more about this in the behavioral health meeting on Tuesday.
Absolutely.
Thank you so much for your explanations and that last story about how you were overcoming a barrier. And we've got various barriers here. I just hope as a community we can work through them so that the facility is everything that we were expecting when we built it. And I apologize, I have to go, but thank you so much.
Thanks
really
for joining
appreciate
us,
it.
Peter.
Of course.
Hey,
you
Peter.
take care. Bye-bye.
Yeah, Todd.
I got
sure.
Follow up kind of so in terms of the utilization numbers.
Yep.
From what you're saying, is like people with insurance issues, substances in their system, health conditions that are difficult to admit, combative, all that stuff with the providers. Is it fair to assume then we do have a fair number of people that are showing up then that can't get in, which is not a bad I mean, it's a problem, but it's worse than just people not showing up. Because most of your explanations for those numbers seem to be there are potential candidates being referred that we can't admit. Is that like the bulk of the underutilization?
Right. And that's a great question, Todd. I think that, one of the things that I was looking at, for example, was referrals received, this, what fifth column over, that it's like, well, in 2022, there was, 2,684, a few less referrals received in 2023, which is kind of interesting, like not knowing, why. I mean, we can extrapolate a little bit of information, but I believe two things, and I'm not hesitant, but I'll qualify my statement and say I don't know that I can prove this, but just from exposure and experience, this is the general premise that I'm suspicious is that there's some accuracy to this. I think that we have good referral numbers. I think that we can increase the utilized beds with bringing some resources and also being able to, uh, uh, work through some procedural stuff with the providers. I think that we can increase those utilized beds. That is, I think that we can accept individuals that have been referred that are a little more, of those entities or those individuals that are viewed as a risk or liability for the providers, and that we can support the structure to a point of where there's less concern about liability.
Do we know what percent of those referrals are actually admitted?
I don't know that I do have a really solid number for that. One of the, things that, and it's always, of course, going to be this way. This is self-report, if you will, by the providers. Not that I'm, suggesting anything relative to that it's inaccurate, that sort of thing. But one of the other, components that we've been pursuing is specifically individuals that are declined admission and why. What was the date? You don't have to tell us the person, the person's name, just, age would be fine, to give us kind of a reference, and why were they declined. Now, again, it might be primary health issue. It could be, the sophistication of the detox. that puts their life, at risk, and they really need to be hospitalized to go through that detox, which then excludes them from coming to this level of care, because if they did, get medical detox at Swedish or at Peace Health, then they are excluded from, being admitted to this. So those kinds of pieces. And in 2024, drilling down into the declined admission individuals. I think working on the other side of, looking at, we do some tracking relative to individuals that have, I didn't include it in this, so I have the data, that did not complete their recommended, stay, which again is 3 to 5 days. That it's like, I think that again, that's another important one, that it's like, oh, well, let's just, sort of feed the front, with the referrals and so forth. But it's like, well, wait a minute, how are we doing with this completion, of services, which oftentimes ends with what we refer to as care coordination. That being, we got you connected to your prescriber, we got you connected to, a mental health, specialist, or whatever, other resources, housing, those kinds of things that are going to, bring about stability, further stability. And my experience at this point in time in targeting those, for any number of reasons that I guess it's not necessary to go into the details of it, I have found both of the providers to be more and more willing and open to, how can we help? How can the county bring either resources or training or whatever, even up at a state level, if that's, necessary, in order to have an impact on this. I will also say that there's 16 beds, and some of this is impacted, although I wouldn't say, that it's a significant impact. Staffing has been an issue, but I don't believe that it's a primary issue relative to bed utilization. We don't have, enough staff. It was, I think, a factor for sure during COVID, and we're all familiar with, the behavioral health impact and, and et cetera during the COVID time, as far as behavioral health professionals. But I think that, again, for example, Pioneer Human Services has an intake person that's trained, skilled. This is a nursing staff and so forth. And so when a second call comes in for an intake, for an individual to complete an intake and, and be admitted, and the nurse has just started an intake with an individual that may take an hour or more, they're not available, at that point in time. And so, it becomes this sort of like, well, there's periods of time in the day that there's a high demand and not enough staff. And there's other times during the day or the evening that there is enough staff and not enough demand. And it's, and it's that balance. And again, a simple answer feels like, well, let's just tell the provider you need to hire additional staff to be able to do this. Well, we run into, obviously a cost, issue and so forth. The other thing that I will say is that if I had to take a guess, and it is this, just from my past and working in both an outpatient and an inpatient setting and being responsible for admissions and et cetera, I would be feeling really great about the services that are being provided if we were at 80% and higher. Getting to 100%, I don't believe mathematically is possible. I don't know what that number is, but I would feel really positive about what was, occurring in, our utilization of the facility if both Compass Health and Pioneer Human Services were at 80% at any given time, on any given month, if you will. Admittedly, what we do also see, and we can, look at the more extensive data, through the year, interestingly enough, during the warmer times of the year, people are less oriented to go to an inpatient setting. And they're more oriented to go during more difficult, weather times of the year. I'll leave you to your conclusions, in that regard. So I hope I'm answering the question, Todd. At least those are my thoughts about that. And very much out of that has been, so the other thing that I'll say, I really, really appreciate working with my manager. I think that most of you folks know Melora Christensen. I've really appreciated working with Melora because her orientation towards the providers in the community is refreshing, and that really is, that orientation is, you are absolutely essential. You are very important to us, and we are in a partnership with you. That, sort of compared to other times that I have worked in communities and been a provider myself, of where the message was, you are disposable. If you don't do the work, we're going to get rid of you. And essentially, the complaints or, the concerns and so forth were placed on me as a provider squarely. And the relationship was really one of hierarchy and threat. And it wasn't something that I wanted to be involved in, to be honest, as a provider. And I really didn't want to be involved in it as a contract administrator for the county, and that sort of thing. But instead say, why are we having a problem here, and how can we help, and what resources can we bring? And that's very much been the context of of the relationship. I think it's a much more successful process. We obviously have a responsibility to obtain the services and the resources that we're funding. We don't happen to be funding the services in this given situation, but in other ones we are, and so there's also a certainly a level of accountability, and and et cetera. So hopefully that's helpful, just in terms of the orientation. I very much believe that it is a successful approach. If we sort of boil it down to the carrot and the stick, I think you get a lot more mileage with the carrot than otherwise. So went on and on there, Todd, in terms of attempting to answer your question. Was that?
Yeah, no, that's good. I'm curious to hear about the law enforcement drop-off stuff.
Yes, absolutely. So super quickly, as we sort of run across these, because of course I lined everything up so you can sort of bounce back and forth between Compass Health and Pioneer Human Services. Law enforcement drop-off, I suspect, I don't know this for a fact because it wasn't identified, but there's this LE is law enforcement drop-off. In 2022 at Pioneer Human Services, 19 individuals, has, obviously nearly doubled in 2023. I think predominantly through the work of Bellingham Police Department. EMS, we have challenges here when it comes to EMS. We're actually making reference here, in my opinion, when we talk about EMS, of the community paramedics specifically, as opposed to more generally EMS. I think that folks are aware that EMS can, at this point, because of WAC and et cetera, can only transport individuals to the hospital. They cannot transport to an alternative location at this point. But I do know that Mike Hilly is doing work within the state and within the county to make that EMS delivery, as opposed to the emergency room, if you will, directly to the facility, particularly, at least in my opinion, and I suspect true for Mr. Hilly as well, for individuals that EMS has responded to for an overdose. Those individuals have to be transported, other than community paramedics, have to be transported to the hospital. So that's why those numbers are as low as they are, or they are what they are, kind of thing. LEAD, we're familiar with LEAD and GRACE. I'll just sort of leave those numbers there. Mobile Crisis Outreach Team is our county designated crisis responders. that do the involuntary and at times voluntary, ITAs. I think that everybody's pretty familiar with that. Obviously, the numbers are lower for Pioneer Human Services. Those are not involuntary treatment admission, kind of oriented folks. 3 in 2022 and 6 in 2023. Those are individuals that their substances are to a point of where they've got the attention of an individual and somebody is called a DCR or possibly the mobile crisis outreach team. That's Compass Health, a voluntary component of the mobile crisis outreach team. Obviously, our numbers are higher with Compass Health 94 and 52. At this point, I don't know what the drop from 2022 to 2023 for the DCRs are. Interestingly enough, Whatcom County has some of the highest numbers for involuntary treatment admissions in comparison to the other 5 counties in our region. No one has really been able to ascertain why. That there's lots of theories about the border bounce back and some of those, kind of components and so forth, but at any rate. Peace Health is the next one connected to it, and Peace Health absolutely is a high user, and I think appropriately so, of the Crisis Stabilization Center, both for detox, as you can see, and for mental health triage. We continue to do a fair amount of work relative to the communication between those entities. Sometimes we run into challenges of where the hospital will say, this person is admissible, to the Crisis Stabilization Center, and the provider may feel that the individual is at a higher risk and or does not meet criteria for this level of care. And there's a little bit of, back and forth that can go on there. So we continue to work with those relationships. We touched base briefly on jail. More individuals that are released from jail that need some stabilization before they go on to possibly an inpatient mental health program and or are released to the community. And Compass Health has been more than willing to take that individual on and really focus on the care coordination and release component on discharge, particularly medication and housing and those kinds of things. Other professionals is exactly what it sounds like, that are referring to the facility, and those numbers are historically fairly high. Self and family, and then also base camp, which I'm thrilled to see a higher number of base camp being reflected there, just because a lot of times that's a client base that is really in need. I'll move on to other topics here, but can certainly answer any other detailed questions as I kind of ran through that one. All right, I'll take that one down just so that we can see each other along that way. So we've seen, an increase in use by law enforcement and first responders, for that matter, just in general, as far as both detox and mental health triage, and continue to work in that relationship. It's been interesting. I have a number of friends that are in law enforcement, predominantly law enforcement. I don't really have friends that are in other kinds of first responder responsibilities. And I have to admit that it was interesting to me, and I've done quite a bit of preaching, if you will. I'll put that in quotes, in working with the fire department and EMS and other first responders that had a negative experience in going to the facility because the individual was on oxygen or the individual was incapable of caring for themselves, relative to their, the daily living, components, and they were declined. And I think that 2 things were really happening there, and we're working on one aspect of that and continue. Well, we continue to work on both, but one of them was that the providers view law enforcement, let's just say, or first responders, it doesn't really matter. They bring an individual to the facility, and for one reason or another, well, they bring an individual to the facility, and so the providers will say, stand by, we want to get you on your way within a 10-minute period of time, but we need to do a really brief intake with this individual before you go. And so one of the questions that I had for both of the providers was, why? What am I waiting for? Well, if the individual is not we're not able to admit them, we need law enforcement or whoever the first responder is to take them away. And it's like, why? This is obviously very expensive transportation. They are in an evaluative setting and situation at that point in time. And so really, when I think about it, it's not desirable to have law enforcement or other first responders transport the individual, even if they're unable to be admitted to the facility. Now, so one of the things that we've done, I think that you're aware that we now have a behavioral health aide, an individual that provides transportation within the community for individuals that either need to get to an appointment or a variety of things. But anyway, we've got an individual that works within the response systems division that drives a van. They can, providers, whomever can call the individual and say, hey, I've got Perry over here. He needs to get to an appointment. Can you transport him? It's not emergency transportation, but nonetheless, it's just we run into transportation issues all the time. And so that's been wonderful to have that resource. And I have continued to, and they have at times out at the Crisis Stabilization Center, utilized that resource. In addition, working with, at this point, the providers to give them funding from the Behavioral Health Program Fund of flex funds that would allow for as appropriate, Uber or a taxi or whatever. So in essence, when law enforcement or their first responders come in, it's like not a problem. If this individual for some reason isn't admissible to the facility, we have transportation for them. Hopefully it doesn't have to be, medical transportation to the hospital, kind of thing. But
Will some of
beyond
those
that,
people be in the 23-hour facility once that is up? Is that part of the idea?
That's a great point. And I think that what we're also going to see is a dramatic upswing in admissions at the Crisis Stabilization Center by virtue of sort of, moving through the 23-hour crisis relief center. I'm involved in the development team for the 23-hour crisis relief center. And my first and foremost recommendation is, number one, we've got to get the existing providers in on meetings right now, years before we actually have the building built. And they need to be using the same intake forms, because you and I both know, we've been to the doctor. They always ask the same basic questions of, name, address, date of birth, those kinds of intake forms. So it's like we can already fill out that intake form at the 23-hour crisis relief center in the possibility that that individual is willing to accept some more extensive mental health stabilization and or detox. And therefore, we've already made a really rapid onset to, the individual being admitted into a longer term stay. Yes, Steve.
So just wanted to give some input from our perspective, and we'll have to have further discussions. A lot of this is a branding of what the patrol deputies feel they're able to bring somebody in for. For example, when we think of a 12-hour hold or bringing somebody to the Crisis Stabilization Center for an ITA, Involuntary Treatment Act, and then we learn that the facility is a voluntary facility, and they can leave anytime they want, it defeats the whole point and purpose of why we're bringing them in the first place rather than jail.
Yep.
So ultimately what ends up happening, I think, from at least the rural deputy standpoint, is we'll just bring them directly to the ER because there's more, they're going to be accepted because the emergency department will clear them prior to, and B, if they make it to CQ, they're going to be held and not released until they're stabilized. So for the 12-hour hold, when we look at the little card about whether or not they're available, it very clearly indicates that once we drop them off and we're diverting them to this hold prior to, or rather than sending them to jail, that there's kind of an expectation that they'll be held for the 12 hours. But right. The truth is they won't. Right. They can voluntarily walk out as soon as law enforcement drives away. So whether that's with a 23-hour facility, and to be honest with you, I'm not knowledgeable enough to know what the differences will be.
Right.
But just so we know from the law enforcement side exactly what is or isn't acceptable. But when it's advertised as a 12-hour place to bring people and they're licensed for 12-hour hold, but then we learned, well, they're actually not. It's
Right.
voluntary and they can leave whenever they want. It sends mixed messages to us. So that's what we're trying to clarify and get consistent information out to our field deputies.
Sure, and it's a great point and a great segue to talk about this other component. Number one, I'm thrilled about the increase in law enforcement drop-off. I'm not talking about 12-hour holds at this point. I'm just thrilled that law enforcement are like, oh, hey, it's okay. You can, I mean, you're only there for about 10 minutes, and if you got somebody and it's, it works, we can drop this individual off and their needs are being met and so forth and so on. Those numbers are actually going up, and obviously word of mouth, from officers and deputies is really important, and it works both ways. It's a double-edged sword. I'm really aware of that. So I'm thrilled about that particular piece. But moving on from there, in regards to 12-hour law enforcement holds, I can send this to you if you haven't seen it, Steve. We're actually making reference to RCW 1031-110 that allows a facility to be certified to hold an individual for a 12-hour period of time. That's where that language comes from when we talk about 12-hour holds. I mean, it's literally coming from, the legislation. You're absolutely accurate that it's like, yep, the facility is not certified at a level to be able to go hands-on, is the simplest way to put it with a client, whether we're talking about detox or we're talking about mental health stabilization. That is an evaluation and treatment facilities are involuntary facilities. I believe that our nearest one is in Mukilteo, that's within our region. But if an individual goes through a process of ITA and they're held at a facility, it's either going to be the hospital within, the Whatcom County area, or at times we'll utilize Compass Health happens to run the evaluation and treatment center, what we quickly call the ENTs, down in Mukilteo. And there's others. There was one in Everett, but it's being rebuilt. And so it's true. It's interesting to me, and I don't know if this actually works for you, because I'm not law enforcement, and so I don't profess to know, the sort of detail of that. But if I have an individual that is a low level, crime, that I can really actually kind of make that determination of whether or not I'm going to take them to jail or not, or even if the jail, because of just for prior things or what's happening with us in terms of the jail, and availability and so forth, that it's like not likely that this is going to be an appropriate booking for jail. I still have the alternative to say, well, I could take them out to the crisis stabilization center and I can let them know, and it's a verbal, that it's like, listen, would you like to go to jail or would you like to go to the crisis stabilization center? I'm going to run through this really quickly. And the individual says, oh, geez, I'll go to the crisis. I've been there before. I'll go to the crisis stabilization center. This is only for mental health triage. It's not for detox, because they can't be licensed in detox. It's just, again, legalities. But the individual, needs that, support and service. The staff are going to work with the individual and use the tools and skills that they use for individuals that are experiencing mental health challenges to keep the individual there for 3 to 5 days. But the first 12 hours, which particularly if it's into the evening, is, probably most of the time is going to be spent sleeping, but we can get you something to eat. They are, I don't know if you're aware of it or not, but they're single and private rooms. So it's like, hey, you got a private room, a warm place to sleep. We got food, come on in, kind of thing. And so I guess it does two things. One, of course, I'm hoping that the individual won't abscond from the facility. If they did, the 31-110, as I made reference to, the responsibility of the provider is to make contact with the sheriff's office, in your given situation, and report that Perry Mowry, left before his 12-hour period of time. And if we had the cell phone number for the deputy, we would, call the deputy, but that individual may be off shift, of course. But anyway, we have a responsibility to report to, the services. I guess, this is is, you know, my inside voice, and I'd be dangerous with a magic wand for sure. But I've often, you know, kind of wondered about, well, I'd sure like to try this, you know, for individuals that don't have a violent history, for, you know, individuals that are right on that line between, do I take him to the jail? You know, because this is obviously, you know, there's some mental health stuff going on here, you know, and so I could, you know, possibly get this person engaged in some support and some services instead of, you know, just kicking them loose, or taking them to the jail, you know. But I get it, that it's like, you know, no way, this person's got an attitude, they're definitely gonna, you know, be a problem. I'll probably get called back out there, you know, or BPD will get called back out there if I drop them off there, you know, and etc. But I'd sure like to run through some successes and failures if I had the opportunity, because understandably, standing back and looking at it, it's like, well, it's a voluntary facility. You can't stop them from leaving, so they're just going to walk out the door. And it's like, well, yes, certainly possible. Or they're going to be pretty open to the, you know, the services that they're being provided, you know, at that point in time, and we can engage them. You know, I can
Sure,
offer that.
and I guess from our perspective, at least on the current situation, these persons who would be eligible for this 12-hour hold, we could never book them into jail anyway,
Right.
just because of restrictions. So
Right.
yeah, I certainly like having some sort of option that's available rather than just citing and releasing. That's not a problem, and perhaps we're conflating two issues from my perspective about persons who are, because of an extreme mental health disability, we have to ITA them because they're suicidal or a risk,
Right.
and then that's an alternative to bring somewhere other than the ED, because ultimately that's where we end up going. And it's just getting the very clear guidelines about who would be eligible to take to either the 23-hour facility when that's open, or the crisis stabilization facility, or whether or not, by virtue that they're incapable of taking care of themselves, if we find somebody who's naked and it's 20 degrees outside and clearly suffering from an issue,
Right.
would they be eligible to go to the crisis stabilization?
Right.
So just
So
getting us clear guidelines, and there's a nice little visor guide that we have, but
right.
a lot of it is just going to be training and education for our folks as to who is eligible, because
Yep.
ultimately we want to reduce the load to the ED, because everybody we drop off there has to be medically cleared. That
Right.
could be hours, and
Right.
we just don't have the resource to sit with them the entire time.
Absolutely. And we're actually communicating, Response Systems Division, you know, the group that I work with, Melora Christensen and all that. We are working directly with the hospital also in regard to that, and have meetings regularly to talk about those pieces. And again, consideration ideas have been thrown around too. Maybe we need to have a Response Systems Division staff that could be out there with the person, because certainly understandable that law enforcement, they're needed someplace else. You know, this is not what they need to be doing. And so would that increase the likelihood, you know, again, of an individual not getting engaged in the judicial system, but engaged in the, if you will, the medical or the, you know, the mental health system. One of the things that I will also tell you is that at the Crisis Stabilization Center, Compass Health happens to be our designated crisis responders in the community as well. And some of the individuals, well, most of the individuals that are there are pretty highly trained in, you know, just in regards to that kind of investigation process. But there is a requirement at the Crisis Stabilization Center that if an individual is demonstrating the likelihood of being a risk to themselves or others, that they have to have a DCR, be able to do a review with them. I want to say it's within 4 hours of the individual being, you know, brought to the facility. So just know that that other piece is already would be in play. You know, if an officer's like, I don't know whether to call it a DCR or take him out there, it's like, well, you'd actually be accomplishing the same thing if you took them to the mental health triage, because they would bring a DCR in, and obviously have a pretty direct line to the DCRs because they both work for the same company. Not that, you know, law enforcement doesn't have a same direct line as well, but pretty exciting here, I think also, and that is a 23-hour crisis relief center. very different dynamic here. So let's just forget for a minute about the Crisis Stabilization Center, although they're going to be really closely connected. The legislation, and I'm happy about this, the legislation says that the 23-hour Crisis Relief Center, which the plan is to have it built in the same campus there on Division Street, that they cannot refuse law enforcement drop-off, period. No matter what. The only exclusion would be that the individual is in such significant primary health risk. They're bleeding out. That it's like, take them to the hospital, let's go to the hospital. And of course, you know, the deputies and officers are going to know that, you know, already. But they don't have to determine, is this guy ill enough? I mean, is he detainable? You know, all those things. And in the 23-hour Crisis Relief Center is also both, if you will, substance use disorder and mental health, all the same staff. So you don't need to determine, does this guy need detox? Does this guy need medication? I don't know. I don't know what's going on. And so part of the legislation, and again, I can provide this to you if you, I'm sure you don't have a lot of time, but I have, some of the outline legislation relative to law enforcement. And I think that that's really, really intriguing. Now, a lot of individuals are going to utilize the 23-hour Crisis Relief Center to just stay for that period of time. And I don't want any services, thanks, but no thanks, see you later. And that's okay. I mean, we can get them some food. We can, offer them, hey, there's some, temporary housing or maybe a prescriber, who knows, what we can offer that individual. But if they're like, nope, no thanks. If the offer is, hey, would you like to stay a little longer, at the Crisis Stabilization Center and, get a little more stabilized, get your medication, whatever, however they approach that, they can literally walk them across the parking lot, introduce them, hand over the paperwork, and et cetera. So I think for law enforcement and first responders in general, I think it's going to be a game changer because there is a requirement within the legislation that the staff cannot refuse. I mean, not that we want to refuse, but the staff, there is no turning down law enforcement or first responders when we're not at capacity. We're looking at capacity at this point in time, just in comparison to our population and so forth and so on, and saying we should probably have the used recliner beds. And again, I'll send this to you, Steve. But
Jill's got her hand up. I'm wondering if.
Oh, yes. Sorry, Jill.
Oh, no, go ahead, Todd. I just wanted to, Perry, you probably didn't get my email. We have another meeting beginning at 11, so I'm hoping we can wrap up here a little bit early. You probably didn't get my email.
Not yet. You're accusing me of being chatty, Jill?
Not at all. Not at all.
Yeah,
Thank you.
My hand was up because I got to jump off.
Yes, of course.
But before that, because I mean, when we were first discussing the Crisis Stabilization Facility, whatever we call now, that the law enforcement having an easy handoff was one of the main goals.
Yes,
we did have the discussion and intentionally designed it to allow the involuntary 12-hour holds, but I guess we can't staff it that way. So I want to encourage you and Steve and law enforcement generally to kind of continue those discussions about how to reduce the barriers, how to incentivize the drop-offs, and not just to keep people from going to the jail, but also Peace Health was really interested in keeping folks from going to the emergency department. So
absolutely.
The more we can, and it's great to see those numbers moving and seeing the law enforcement drop-offs, but because it's going to be a while before we get the 23-hour thing on the ground. So the more we can do to coordinate and have these kind of discussions that I'm now like leaving. Sorry.
Yeah. No, absolutely.
I really appreciate working on collaborating with the sheriff and BPD to like make this work for everybody. So thanks, Perry.
Absolutely, Todd. Thank you. So, Steve, I will, like I said, I'll send you this copy of the RCW 1031, just, long,
I've got it.
12-hour. Oh, okay.
Yeah, I'm looking at it right now.
But you're absolutely correct. I think that, law enforcement personnel are like, I don't see how this works, so I'm not going to, going to spend my time, with that. And I think that I do continue, as I had shared with you, to sort of share the concept that it's like, well, if it's an individual that's right on that line of, boy, I'm just going to probably cite and release them. The one advantage, and it's interesting because I have somewhat this similar conversation with the public defender's office when they don't want to have an individual go the route of being involved in mental health court, which is about a 2-year period of time that the individual is involved. And they're like, well, we don't want to see that consequence occur for him. And what I tend to preach is this is a wraparound service of mental health services, prescriber services, and et cetera. And maybe the most stabilizing period of time that this individual has experienced for years. So it's not really, if you will, a punishment or, a consequence as much as it is, access to a resource, because that's where the staff are going to be oriented. Obviously, less so with bringing an individual to the crisis stabilization center. But, again, people oftentimes, as you're probably aware, one of the things that we'll see is an individual, for one reason or another, will get away from their medication because they think that the side effects and so forth. When they do get away from their medication, they begin to experience psychosis. They have an interaction with law enforcement. They're psychotic. They think that, the person's an alien or who knows, what it is. And then, maybe take a swing at the person or, or the law enforcement officer and et cetera. And it's like, oh man, here we go, down a, road that's just so ineffective, for this individual. Now, we may not be able to avoid that. It is what it is. And I've got honestly nothing but respect as far as law enforcement and the challenge of the job, particularly when it comes to mental health, challenges.
Sure. I'm sorry, I didn't want to imply that we view it as a lesser form of punishment. We're very interested in providing folks treatment when needed.
Yep.
The concern is that if, let's face it, a lot of our clients are frequent users of the systems, and
Yep.
when they learn that it's just a drop-off point for them and they can leave, then rural law enforcement also has to take into consideration we don't want to just simply burden municipal law enforcement with problems by taking them now to a city facility that they're just going to walk away from and become
right.
problematic again. So
right.
we keep that in the back of our mind. And
yep.
These are conversations we're not going to fix, but we really do appreciate having multiple options of what we can do. And with our mental health deputies coming on board and now the co-responder groups getting up and running, we fully expect that it'll be utilized more and everybody will learn what we can and we can't bring. So we appreciate the conversation for sure.
Right. Yeah. And and you certainly didn't imply, otherwise, and, as well as when you make reference to, the rural, deputies and law enforcement, there's consideration for the time that it takes to get from wherever they are to the facility itself. It's like, okay, is that worth, the effort if in fact the person could simply walk out the door, not to mention that I may be, transferring a challenge, and to, the city and et cetera. One of the things that 2024, I had initiated some in 2023 and am committed to that in 2024 as well, is showing up to muster if invited, to shift change, and talking really specifically, going over obviously the visor cards and just saying, this is what this means and this is why, can I answer any questions, and just being very candid with folks and saying, realize that this is fully your decision, and not being law enforcement, I don't know all the challenges, that occur, but this is what we're working with, this is what we're working on. And it is interesting because one of the things that I've really appreciated with the providers as well is, I think that when we originally opened the Crisis Stabilization Center, it's like, oh yeah, law enforcement, they drop off and et cetera. But because we have continued to communicate with the providers and say, listen, law enforcement is frustrated. They're, being asked to wait. They're calling to see if there's a bed available, and there's all these questions, and there's just a lack of clarity. There's no need for this, and this is what we'd like to, recommend as far as the streamline. They can call, they can go, is there a bed available? Yes, there's a bed available. That's what I needed to know. I'll bring this individual over. And I think with this transportation piece, that it's like, listen, I'm not talking 12-hour holds here. I'm just saying that as an officer brings somebody or a deputy brings somebody that they're like, yeah, I'm going to spend less than 5 minutes here. I'm going to walk the individual in and say thank you very much and bye, because they have transportation, they have everything they need. I did get some feedback at at various times that it's like, well, if an individual is marginal in terms of being combative or whatever, I know I may just get a call to come back there because, the individual begins to really act out or whatever. And it's like, well, it's possible, certainly, and that's wouldn't necessarily be inappropriate, but these are pretty skilled staff in working, de-escalating individuals, and so forth and so on. I don't know, Steve, I'm glad that I got the opportunity. I don't know if you were, ever plugged into this or whatever. Compass Health had to actually go out and get a specific certification from the state for being able to provide 12-hour law enforcement holds. You have to literally be certified to do that, in addition to being a mental health stabilization facility. So they went out and did that. They actually had to have some additional staffing requirements, training, and et cetera, and they completed that. And so they're literally licensed and staffed, for that opportunity. The last piece that I had was that is I know you've looked it over. The 1031-110 specifies that the prosecutor's office has to also be involved in terms of basically identifying, my understanding in kind of layman's terms, but identifying the kind of potential charge that could be deferred to a 12-hour hold instead of, et cetera, et cetera. Well, I approached the prosecutor's office in that regard and, and laid this out, having honestly, this is my own sort of defensiveness and frustration, but having sent that information over to the prosecutor's office a couple of times in the previous year and saying, would you please look this over, because we're working on this and developing it, and I don't want to do it in a vacuum. Well, when I finally met with the prosecutor's office, the prosecutor said, I think our liability is really significant here in dropping off individuals. Instead of dropping them off, taking them to the jail, we take them to the, voluntary, crisis stabilization center. I'm going to turn this over to our county attorney, George, that Roche, that I have him review this, and we'll kind of let you know where we stand with this. This is basically the way that the meeting ended. I later was contacted by George Roche, and he said, well, listen, Perry, the sheriff's office is my client, and based on client confidentiality, I really can't tell you what I'm advising them. But I am working with them. I am advising them in regard to this 12-hour law enforcement, hold concept. So thanks so much for your time. Have a nice day. And again, I really understood where he was coming from, even though I work for the county as well. But I realized that it's like, well, no, this division of the county, if you will, the sheriff's office is my client, and there's lots of, different departments, if you will, of the county. And so it sort of at that point just came to a stop. And again, that it's like, well, I made every effort, everything that I could think of to move this forward, to make it, as much of a resource as possible, et cetera, et cetera. And it's without having facts, one will come to their own conclusions, however inaccurate they might be. I'm sure you've experienced in your career. I'm like, well, okay, so the sheriff's office doesn't want to proceed with this. So I'm not going to hear anything else about it. Now, I don't know at all that was accurate, but obviously a significant amount of changes has also occurred in the sheriff's office, as well. So
We've been here for 45 days, so we're learning stuff.
Right. Absolutely. And so I continue to be available, whether that's coming and talking with shift changes and and et cetera, or you're right, it's a fairly sophisticated concept of wait, who's eligible and who's not eligible, because that's honestly what the behavioral health experts do. And so it's something I'm hopeful for, that we have that option, but honestly, I'm just thrilled to see law enforcement utilizing the Crisis Stabilization Center just in general, and finding it to be a viable option. Not necessarily between jail and that, but finding somebody that really needs some help and going, I know where to take it, and this will be a good thing. I hope you hang in there, kind of thing. So really appreciate those efforts, and also, the challenges, as well. So I think that I covered, in my wandering ways here, I have quite a list of goals in working with the providers through 2024 to facilitate that, and then bring that information to law enforcement in general. And you're absolutely correct. John Dukes, great supervisor with the art team, with the co-responder team. I'm fairly involved with those folks as well, and I agree, the more relationships and sort of interactive dynamics that we have with the sheriff's office, the better it's going to be in terms of Crisis Stabilization Center information back and forth, as well as the 23-hour relief center. And like I said, I will send you that legislation too, because I think that it's going to be a great benefit for law enforcement. Matter of fact, I think that law enforcement and first responders are going to be the predominant utilizers of the 23-hour crisis relief center. The challenge is, again, we've got the land and so forth and so on, but the challenge is that it probably won't be built for at least 4 years, and that's a long ways out for some of the challenges that we're facing right now. So really appreciate your time, and certainly willing to answer any other questions. I know you got my email, so I hope you'll reach out.
I will. Thanks, Perry. Appreciate it.
All right. So Jill, I think that we have gotten through the topics and points of the subcommittee meeting. I know that we also want to engage community input, if there is any.
Thank you, Perry. Yes, I just want to let our attendees know we lost our quorum, but we still have a few minutes. If you'd like to speak to the remaining committee members, please virtually raise your hand now by selecting the raise hand icon. And I don't see any hands raised, and I don't see anyone in our conference room. Thank you, everyone.
All right. Thank you very much. Very much appreciate folks' time, busy days. And so thanks for taking the time to attend.